Marianne Terrani, and I am the co-founding director of the UC Center for Climate, Health, and Equity. The mission of our center is to harness the expertise and leadership of the health sector to drive ambitious climate action for health and health action for the climate. The center is based at UCSF and spans all 10 UC campuses and 5 healthcare systems with over 100 affiliated faculty. Now, today's webinar, which is co-sponsored by the UCSF Academic Senate Committee on Sustainability, is the second webinar of our spring series called The Health Impacts of Climate Change Across Our Lifespan. So last month, we focused on children's unique vulnerability to climate change, and our panelists discussed wildfire smoke and climate exposures experienced by young children as well as adolescents and their mental health in relation to climate change. So the webinar is now up on our YouTube channel. Feel free to listen to it if you haven't already. We'll round out this series next month when our final webinar will explore heat illness, chronic disease management, and mobility during natural disasters among aging populations. So today's webinar will be focused on climate change effects on adult reproductive and occupational health. And it's now my pleasure to introduce today's moderator, Dr. Maria Zlotnick. Dr. Zlotnick is professor of obstetrics, gynecology, and reproductive sciences at UCSF and a maternal fetal medicine specialist. She has a longstanding interest in how the environment affects pregnancy and reproduction. She's also the associate director for maternal fetal health and the environment program of the UCSF Pediatric and Environmental Health Specialty Unit and a member of UCSF's program on reproductive health and the environment. And I'll turn it over to Dr. Zlotnick.
Thank you very much, Dr. Teherani, and thank you all for being here today. I'm looking very much forward to our presentations on climate change and adult and reproductive and occupational health. As a practicing high-risk obstetrician at UCSF, I sometimes wonder if my patient's pregnancy outcome was impacted by climate change. For example, when a patient presented with preterm premature rupture of membranes the day after an evacuation for a massive wildfire. For an individual, we can usually never definitively know why an outcome happened, but the research literature can give us clues. Given this, I really appreciate the work of our speakers today, who have been instrumental in generating the body of research assessing the health impacts from climate change and environmental exposures. I now have the distinct pleasure of introducing our featured speakers, Dr. Catherine Conlon and Dr. Rupa Basu. Dr. Conlon is an assistant professor of epidemiology at both the School of Medicine and the School of Veterinary Medicine at UC Davis. Dr. Conlon's research interests are in understanding the role of environmental exposures on health, particularly focusing on using place-based indicators to explore how disadvantaged communities experience adverse health outcomes. Her most recent research has focused on extreme heat, wildfires, and the confluence of the two exposures. Dr. Basu is currently the chief of the Air and Climate Epidemiology section at the Office of Environmental Health Hazard Assessment of the California Environmental Protection Agency. Prior to joining OEHA, she worked at the U.S. Environmental Protection Agency after obtaining her PhD in epidemiology from the Johns Hopkins University Bloomberg School of Public Health and her MPH degree from the UCLA School of Public Health. Dr. Basu's work is widely cited and has received a lot of media attention, including in the New York Times, LA Times, San Francisco Chronicle, the New Yorker, BBC News, and NPR. I will now turn it over to Dr. Conlon, who will present on occupational health, and Dr. Basu will follow with reproductive health after. We'll then have time for Q&A, so please put any questions you may have into the Q&A box throughout the presentation. Thank you very much.
Great, thank you so much for that introduction. So as was stated, we'll get started with a discussion on occupational health and climate change. And this is going to be fairly broad because, as you might not be surprised, climate change touches all aspects of occupational health, and that means that it touches all types of workers. And it's not just that climate change is an environmental issue, it's also a human rights issue because it doesn't have equal impacts and it acts as a threat multiplier. And what we mean by that is that it really does impact everybody. And what I want to show here with this figure is really draw your attention to the seasonal distribution of temperature. Here we're looking at a figure from Berkeley Earth that is showing us monthly average temperatures since 1850. And really the real focus here that I'd like you to pay attention to are the last 3 years. So 2021, 22, and 23, which are shown by these orange, red, and black lines. And what we can see with the black line for 2023, the monthly average temperature in January was similar to that in 2021 or 2022, but well below the previous record level. However, the monthly average warmth that began in June continued every month through the rest of the year in 2023, often beating the previous monthly record by a large margin. September had the largest monthly anomaly that was ever observed, and December came in and the second largest. And this is important because as we're thinking about occupational exposures, we can think about why these monthly temperatures are important and who would be exposed when these anomalous temperatures are occurring. 7 months in 2023 were at least 1.5 degrees Celsius above their corresponding 1850 to 1900 average. And that 1.5 degrees Celsius number is important, as we know, because that was a goal that we're thinking about with the Paris Climate Accords. So workers, particularly our outdoor workers, are among the populations most disproportionately affected by climate-related hazards. Workers in agriculture, environmental goods and services, construction, emergency repair, transportation, tourism. Those are the populations that we're really focusing on when we're thinking about outdoor workers. And heat, of course, is predominantly the main exposure that we think about when we're thinking about outdoor workers. And it is perhaps the most studied exposure. Excessive heat affects 70% of the global workforce, which amounts to 2.4 billion workers that are exposed. The impacts range anywhere from heat stress, heat stroke, and exhaustion, to fainting, to heat rash, to more serious outcomes like acute and chronic kidney injury, to cardiovascular disease, death, and as Dr. Basu will be talking about, some birth outcomes. And as a share of the growing global population, the proportion of people who are exposed to extreme work-related heat has increased from 65% in 2000 to 71% currently. And this is coming from a report that was just released last month by the International Labor Organization. And we can think about where this distribution of heat is actually occurring. Here, we're looking at a global map that shows the geographic distribution of monthly means of daily afternoon wet bulb globe temperature, which is just a measure, a fairly accurate measure of how we experience heat. And it's actually measuring temperature in the shade. And the map is showing current values for the hottest month of the year anywhere in the world. So it's showing shaded wet bulb globe temperature in January for Australia, whereas it's showing wet bulb globe temperature for July in the US. And what we're seeing are the most dangerous heat levels are found in the tropical and subtropical areas of the world. And the majority of our low and middle income countries and large parts of the US and Australia are located in this region, so that when heat waves occur, the individuals who are performing labor in those very hot conditions are going to be exposed to those conditions. And so they will be expected, to operate in those conditions. And then if needed, they will be needing adequate resources such as clean drinking water, personal cooling strategies, active and passive cooling to cope with the increased temperatures. And so you can think about how these types of cooling or adaptive strategies are going to be requiring more resources as time goes on. We can think about what those future scenarios might look like. And I present this study that was done by Dahl et al. In 2019, which is showing mid-century model results, looking at the mean number of days per year with a high heat index value. So heat index is a combination of temperature and humidity. And really what we're seeing here is that across most of the US, the frequency and geographic range of these high heat index days increase markedly under two different scenarios. So the top scenario is what is called RCP 4.5, which is kind of a moderate scenario in climate parlance, where we would expect the emissions to peak around 2040 and then kind of decline. So that's one where we're doing a pretty good job of reducing our carbon emissions. But RCP 8.5, the one on the bottom, is one that we call business as usual. This is the current track that we're on. But what we see here is that that the number of days above where the high or the heat index is above 100 double in this high heat, or excuse me, in the RCP 8.5 scenario, and triple where the heat index is above 105. So this is really demonstrating that we can anticipate people who are experiencing these temperatures are going to be experiencing them more frequently. And I just want to point out this is relevant for occupational exposure because we can see visually, as we know here in the United States, where a lot of our agriculture and outdoor workers might be exposed. We in California are familiar with our agriculture industry, and we can see just on this map that Olavo Valley is part of this area where these high temperatures are going to be expected. I show this hierarchy of controls as a way to bring attention to how in occupational health we think about ways starting with elimination, just take it away, or you could substitute some type of hazard if you could. So we can't really do that with some of our climate related hazards. We certainly try to eliminate them, but we have trouble doing that. And we move down through engineering and administrative controls down through PPE. But those are become less effective as we move through for reasons that are very much related to behavior change and implementation and being able to effectively monitor and make sure that people are following the rules. So it's not always the case that we can ensure that policies are followed. In terms of policies, heat standards are those that have often been pushed. I'll note that this tool by the NRDC is lovely. You can access it on the website that's listed below. Only 4 states currently have outdoor workplace heat standards. California is one of them. Colorado has one, but it only applies to agricultural workers. And Oregon and Washington also have one, as does Minnesota. There is a new initiative that President Biden had made note that he wanted to see pushed forward, that OSHA would have a federal standard put into place that started in 2021. And I think is still in some processes right now to be put to move forward. It will take some years for this to actually be put into place, given how policy moves to the federal government. There is a indoor policy that has been pushed in California, but following some pretty dramatic and abrupt changes that just happened last week, it actually has been stalled at the bequest of the governor. And so that is something that is yet to be seen. So we haven't seen it for indoor workers in California. Heat is not the only concern that we have. Air pollution is another. Different air pollutants increase global warming, and global warming in turn increases some of the formation of these air pollutants that include ground level ozone, PM 2.5, PM 10. and the rising number of wildfires increases emissions of particulate matter and ozone. And these aren't just indoor, or these aren't just outdoor pollutants. We're concerned about indoor pollutants as well. And we know that from this recent report that was provided, 1.6 billion outdoor workers are exposed to air pollution annually, and that almost 900,000 work-related deaths are attributed to air pollution globally. These are global estimates. And the impacts of PM 2.5 in general range from respiratory impacts, cardiovascular, development and aging, which we'll hear more specifically about from Dr. Basu. And when we think about who these impact, it's all types of occupations. Really any kind of worker that has any type of impact or any type of exposure to particulate matter. So outdoor workers are of concern, transportation workers, firefighters, of course, are of concern. As I noted, agriculture is an important part of California's economy and employs more than 400,000 people per year. California's Central Valley is one of the primary agriculture producing regions of the state and has some of the worst air quality in the country. And that can be further degraded by regional fire activity. And the Cal OSHA protection from wildfire smoke is the wildfire smoke standard. It was initially filed as an emergency rule in 2019 as a result of of agricultural workers who were exposed to poor air quality during wildfire events that looked very much like this picture that you're seeing here. And it was made permanent in February 2021. So it's kind of a really great success story. And it applies when employers should reasonably anticipate, this is from the language of the policy, that employees would be exposed to wildfire smoke and that the air quality index, or the AQI, for PM 2.5 is over 151. And it has these 5 main provisions: that it requires the employee monitors the AQI and communicates that to the employees. It provides training on the exposure, the symptoms, and the treatments and protective measures that an employee should take. It provides respirators for employees. It reduces the exposure by relocating employees, changing work schedule, providing some type of respite, so opportunities to get away from poor air quality. And when the AQI is above 500, the employer has to require respirator use or postpone work. So it's quite a bit of expectation on the employer to protect the employee. These figures come from the UC Davis Western Center for Agricultural Health and Safety. They're fantastic placards and training materials that are provided in both English and in Spanish that walk through an end user for following this rule. You can see where they focus on both using visual aids to train people, both employers and employees, on how to follow this rule. And they also do so in-person and online trainings like 3 to 4 times a year in both English and Spanish. And I just want to come back to this hierarchy that shows the specific changes that this policy makes, or and how it maps back to the hierarchy. So it really focuses on these engineering controls and administrative controls, and how that policy is really getting at protecting workers during these extreme poor air quality events. This is a study that I think was very well executed and very well done, that looked at the potential of exposure of outdoor workers to smoke pollution under future climate conditions, using that policy specifically. So taking those categories from that protection from wildfire smoke standard and looking specifically at the threshold for the unhealthy for sensitive groups. So when the AQI is above 151, this team did some modeling experiments that show that the total daily number of exceedances, so that top row for past climate or for a past event. So from 2004 to 2009, the estimated number of daily exceedances. And then they did it for future, so mid-century. And then they looked at the change. And what they found was that for the total average agricultural worker in Monterey, Kern, and Fresno counties, they saw more than 50,000 summer outdoor full-time worker jobs. And they didn't see any exceedances of the 150 outdoor workers in the past period, but they did see some in the future. But when they did actually look at where they saw those unhealthy air qualities, Monterey County popped up. They also saw some in Sonoma County. And really, when they started to look at the more hazardous levels, they ended up finding that there were 9 counties in the future climate conditions where they saw much higher worker exposure. So down here in the Central Coast, where it would correspond to about 1,500 worker smoke exposure days in this hazardous category. So really what this is showing us is that we would expect to see a lot more workers being exposed to these very hazardous smoke days when in areas where we wouldn't have being expected it. So there's this shift in where we would expect people to be exposed to poor air quality, meaning that these are places or times when we locations where we might need to start focusing on some adaptation metrics. And I just want to point out that Cal OSHA does have its own training video for this particular policy, and it's available on YouTube. And then lastly, it's not just heat and smoke, which are some of the things that we really focus on, but there are a lot of other, there are some other emerging threats that we can point to, including vector-borne diseases and biologic hazards. So vector-borne diseases are things, that are caused by parasites, viruses, and bacteria that are transmitted by fleas, ticks, mosquitoes. And we know climate change has been linked to these through changes in vector population sizes, survival and reproduction rates. And the greatest burden of disease is happening in subtropical and tropical areas, and they disproportionately impact the poorest populations. And we know that there are also changes in coccidioid fungal diseases and changes in aeroallergens and pollen distribution. Lastly, I want to point out that disaster-related impacts are also of concern for some of our emergency responders who are more notably being documented to have mental health conditions following their experiences providing care and responses to those who are impacted by things like hurricanes, monsoons, mudslides, and extreme events. So it's important to remember that in public health, we as a society are very much charged with assuring the conditions in which people can be healthy, as noted by the Institute of Medicine. And I would like us to be thinking about that as we have this conversation today. So please hold your questions or for the end, or if any come up, please enter them into the chat and we will have them for the discussion at the end. We'll hear now from Dr. Basu about reproductive and developmental health.
Great. Thank you, Katie. I am going to share my screen so I can get my slides up here. And here we go. Okay, thank you so much for having me here today for that nice introduction from Maria and Katie. I am going to present in the next few slides some studies that we have published in the past several years on ambient heat exposure and adverse birth outcomes. So it just seems that the more we study heat, the more we find out. So initially, we really thought it was going to be just associated with mortality. We know that of all the climate change exposures, heat tends to be the biggest contributor to deaths. But not until just the past few years have we looked at heat illnesses, other outcomes such as cardiovascular, respiratory outcomes, diabetes, mental health, which is actually pretty new, liver and kidney diseases, infectious diseases, as well as gastrointestinal diseases. In the next few slides, I will be focusing on just a few studies that we've conducted on adverse birth outcomes, including preterm delivery, low birth weight, and stillbirth. But I think that I just want to show that it's really important to capture all of these health outcomes rather than just looking at the traditional dehydration and heat illness to give the best measure of risk from heat. So vulnerable populations, as I mentioned, we started out studying mortality, particularly in the elderly. Also, we know that there's socially isolated populations are very high risk. People who are pregnant, which I will talk about some more, young children, outdoor workers, which we heard a lot from Dr. Conlon about, including farm workers, and certain medications such as beta blockers, which are used to treat heart disease, or antidepressants, which of course are, we know that mental health and cardiovascular diseases are increased with heat. So this ends up being an effect modifier. Living on higher apartment buildings, particularly on the top floor, often without air conditioning or without a functional air conditioner, and of course other building characteristics as well tend to put people at higher risk. Poverty, which is measured in so many different ways, and I will talk about that a little bit as well. And then young athletes. And I want to mention these populations. Of course, this is not a conclusive list. There's a lot more, but it's just because when we're thinking about heat alerts and we're thinking about public health messaging, many of these populations are missed. And that's important because if people don't know that they're increased risk, there's not going to be any preventive measures taken. And I do want to just really emphasize that these outcomes that I mentioned earlier are mostly preventable. So, you know, given that we identify these high-risk populations and talk about interventions, we can really alleviate a lot of these health outcomes that we're seeing. So this first study that I'm presenting was published back in 2010. And I like to present this one because it was the first large-scale study of heat or temperature and adverse birth outcomes that produced positive results. And since then, I mean, in the last almost 15 years, we've really come a long way in this research. But the overall result was a little bit surprising in that we found that not only are all people who are pregnant at increased risk, you can see here that I have the overall result in blue as an 8.6% increase. We don't have to focus so much on the numbers, but more on the result. That's a pretty large increase. Just to put things into perspective, when we had studied the elderly for cardiovascular outcomes such as heart attacks, we were at about 2.3 to 2.6%. So this was quite alarming to find this. And then also, there's this differential result by race, or an effect modification by race. So on the x-axis, we have, as listed in our data set, Black, Hispanic, white, and then we created an Asian category that is still pretty heterogeneous, but at least we were able to look at this with the California birth certificates. And you can see right away that, as I said, all pregnant people are at increased risk, but there is a disparity. So people who were Black have almost about a 15% increase. People who are Hispanic and Asian also higher risk than those who are white. And we also see a very nice dose response by age. So again, the overall result was at about 8.6%, but younger mothers, particularly those who were under 20, or under 25, and those are both on the very left-hand side here, have even greater risk. And you can see even some of that continuing to the 25 to 34-year-olds. And then once you get to 35 and over, that risk decreases quite a bit. And of course, this is tied into so many different factors, education, including health education, but also other risk factors. Socioeconomic status does play a role. And we know from the previous slide and other research that race, ethnicity also is a huge factor. So after publishing that first study, I think from the birth certificate data, we were very limited as to what variables we could look at. It was really just that age and race, ethnicity, which we know that doesn't give us an overall picture of high risk factors. And so I collaborated with the Kaiser Division of Research, and through a grant at through the NIEHS, we were able to look at maternal factors that could modify the risk between heat and preterm delivery. And not surprisingly, found that smoking status, alcohol use, pre-existing or even gestational diabetes, as well as pre-existing hypertension had a pretty large risk. And if you look at the, we're not focused so much on numbers, but the magnitude of risk is so much greater. So for smoking, we're now looking at 32.4%, alcohol just about the same. But when you have these medical conditions, comorbidities, that's much, much greater risk. And one that I didn't present in this figure is also, well, I didn't talk about gestational diabetes or hypertension, but also preeclampsia. That's another big trigger for preterm delivery. So also very important, but just, yeah, the magnitude of risk was quite alarming. And then after that, just to, tell the story of how our research kind of, there's a lot of studies in between there, but the progress went next to, let's look at other adverse birth outcomes, so such as stillbirth. So this study was published back in 2016. And part of the reason we waited to look at stillbirth is because we didn't have that data until more recently. And so that's, once we got that, we also looked at air pollution and heat here. And of course, adjust for one or the other, depending on our main exposure. What we found here was pretty much in line with what we had found already for our preterm delivery studies. As you can see on the very left here, we have the whole year, and then we have the warm season, and then the cold season. So yes, all year is confers greater risk, but you can see that's largely driven by the warm season. And so in both the preterm birth and the stillbirth, we looked at very acute effects or very short-term effects. So these numbers that you see at the bottom here are lag 2, 3, 4, 5, 6. And then it's a combination of like a cumulative lag of 2 to 3, all the way up to 2 to 6. And you can see that, yes, all the lags have the greatest risk, but based on not just the greatest association, but also the best model fit, we noticed that this weekly lag, very similar to our preterm delivery study, had the greatest association, greatest risk. So then we moved on to looking at another health outcome, term low birth weight. We wanted to do term low birth weight as opposed to just general low birth weight, just because we know that there's other risk factors that come with preterm delivery from our previous studies, and wanted to focus on full-term births that included gestational weeks of 37 to 44 weeks. So in this study, it was a little bit different from our preterm birth and stillbirth in that we noticed that there was actually a greater association with long-term association rather than the acute short-term, just the weekly, the week before birth. So full gestation, for example, had a pretty large association, greater than 10%. That was, I'm sorry, I went a little too fast there. Largely driven by the third trimester. So that third trimester, when we broke it up into warm season and cold season, was also largely driven by warm season. So again, kind of lining up with what we had seen previously, but now we're just seeing that because of the mechanism of birth weight versus the other two outcomes that we had considered is a bit longer term, but still noticing that heat really exacerbates this outcome. Post 2007, we had some other data that we could look at, such as being enrolled in the Women, Infant, and Children program, or WIC, smoking, and body mass index. And you could see that there's associations for all of these outcomes. We had talked about cigarette use before. One that I want to just highlight here is BMI. Actually, we were thinking that like maybe in our Kaiser study, we had found being underweight had increased risk, but here we're seeing that actually it, and I think this is a little bit skewed. This should be over here. So it lined up with our Kaiser study. We're seeing some normal birth weight as well, but overweight not as much, which was actually our hypothesis. And I'm sorry, everything got a little shifted here, I'm noticing. So hard to see that result, but just trust me, that's what happened. Okay, so here I just want to talk about high-risk populations and that they are pretty consistent, but it's really important to look at the exposure and the specific outcome, even for adverse birth outcomes. So here for preterm delivery, we noticed that Blacks, Asians, and Hispanics conferred greater risk, also younger maternal age, or the person giving birth was younger age, hypertension, diabetes, alcohol use, and smoking. So these are just some of the risk factors that were identified from these studies. So taking all of this information and many, many, many other studies, I did say that that 2010 study was like the first large-scale study to find positive associations. Well, since then, there has been so much research done in this field, not just in the US, which I've presented here, but throughout the world with very consistent evidence. And of course, that's really important for causality and other factors, also for policy. So in this review, it was a systematic review that was led by Bruce Picard. I was a co-author on this. There were 68 studies, including over 32 million births for this large time period in the US. And it not only looked at heat, but also fine particulate matter and ozone, other things that we also study, and the outcomes of preterm birth, low birth weight, and stillbirth. I just want to go over the results really quickly. And we just found very consistent results, not just with these associations, but it really, the magnitude was very similar regardless of where we, which study we were looking at, regardless of what kind of study design was used. Also, when I showed you the disparities, that also really held true. So I would say the majority of the studies found this. There were some that didn't, but that just really speaks, that there's really definitely something going on here rather than just this one study that might have been due just to chance. So just wanted to point out, this is like the biological mechanisms, or one of the possible biological mechanisms. Dehydration, of course, is very linked to heat. And, some of the symptoms, nausea, or vomiting, or rapid heartbeat, headache, can also be confused with just, oh, these are pregnancy symptoms also. So I think that it's important to note that there's often not the connection made between like, oh, this could be a result of the heat. And all the studies that I just presented were not due to extreme heat. So when I hear extreme heat, I'm like, well, it doesn't really take extreme heat to see these associations. And it doesn't take, climate change in the future. We're already seeing these effects. We've seen these already. Yes, it'll probably get worse with heat waves and extreme heat. It'll probably get worse with the future projections that we're seeing for climate change, but we're already seeing this. And it's really important to make that connection, particularly for high-risk populations, such as people who are pregnant. So just this dehydration could lead to oxidative stress and inflammation, which then leads to the release of oxytocin. And when that happens in the body, that's of course also an indicator of stress, but it decreases uterine blood flow, and that kind of triggers the body, if a pregnant person, to induce labor and decreased fetal growth, which is why we would have seen some of the low birth weight. And the induction of labor often happens prematurely, which is why we would see the preterm birth and also the stillbirth. Now, I think this is really important to talk about the reasons for the disparities that we talked about. And I think regardless of whether we're talking about California or a county within California, or even going out to globally, we're seeing this pretty consistently also, that the biggest carbon emitters are not the ones that are most impacted. And we can do something about this. So first I want to talk about the exposure. So, most of our studies focus in California, being a state government agency, but we see that there's greater exposure to heat and air pollution. And this is even different by zip code. We see that there's like differences in a life expectancy by zip code, but there's also differences in heat and air pollution. And this is, a result largely to historical redlining. We refer to this as environmental racism or environmental justice issues, but certain communities are just living closer to power plants, fossil fuel combustion areas, freeways, all contributing to greater exposure. Of course, there's also the urban heat island, which means that there's less green space, that there's so much reduction in health outcomes from green space. And with that urban heat island, there's the retention of the heat. So not only are you getting the heat short term, it's this chronic exposure that just stays because of the blacktop and the cement and all the other things that are absorbing the heat. Health outcomes. Okay, so I did mention that, yes, poverty is one of the factors. Lower socioeconomic status, high cost of air conditioning. So like some people, even though they might have air conditioning in their homes, they're reluctant to use it because of the cost. So that's, a big barrier. Also, in the case of a wildfire or a heat wave, relocation may not be feasible for some people, whether they have to just keep working or don't have any other place to go. It could be, there's also, we've seen some differences in access to healthcare. For example, in the emergency room studies that we've conducted, shows that using the ER for primary care really is different by population. But the thing that I really want to highlight here is something that is really concerning, is that even with the same access to healthcare, there might be differential treatment just based on skin color. And, we hear this more and more now, but I think this is really important because, when we talk about, needing to have more, just women, but also people of color, doing this type of work, just to feel like people are represented, that there's someone in the room who understands or advocates for you while giving birth, for example. These are just really important. So all of these things I think could be preventable. I might be going over time here, so I'm going to go through these really quickly. I just wanted to talk about some of the ways that our work is being used. The California's 4th climate change assessment was released in 2018. There is a 5th assessment being produced. So I only talked about heat here, but in California, we also have to deal with some other things such as sea level, snowpack, precipitation, and then also drought, wildfire, which we talked about a little bit. And all of these things are if the greenhouse gas emissions keep going, increasing the way that we're seeing, we could see quite a large impact on temperature. I just focused on temperature here, as high as 5 to 10 degrees by the turn of the century, which of course would have very devastating health effects. So just something to keep in mind. We've also had recent bills in California from our work and other epidemiologic studies, primarily just focusing on improving maternal and fetal health outcomes, looking at extreme heat, and even perinatal and infant children's health specifically, and decreasing the disparity. So that is it. Thank you so much. And I can be contacted here if you have additional questions that you don't get a chance to ask. Thank you.
Thank you so much to Drs. Basu and Drs. Conlon for your great talks. And we've got some good questions coming in through the Q&A box. So I will start off with a question that I think you both would have some really interesting answers to, and I might as well. This is from Neuma. who asks, we talk about reducing heat exposures for when looking at occupational hazards. What type of messaging or intervention is being recommended for pregnant people? Is it just related to occupational exposures, or are there other recommendations being made specific to this population? If you want to start, Katie.
Well, I can say that it's my understanding, and I think Dr. Basu might have some thoughts on this, but from an occupational perspective right now, because there's no federal standard, which is where I think you'd expect there to be like interventions or specific messaging, it really does fall to a lot of like the science around what do we know is the risk for pregnant people and the risk for outcomes related to heat and during pregnancy. And so I think there's this, it's like a very weird, I say weird, there's a very delicate balance right now, because it kind of, it puts like an onus on science, I think, to kind of come up with like the right answer, while policymakers are trying to figure out how they want to come up with a standard, which makes it really challenging to communicate to anybody who's concerned. Say, if you're pregnant or you have somebody you care about who's pregnant and they're worried about their heat exposure. And so there is no, I think I can confidently say, like, there are no really like hard and fast like messaging rules right now. There are no clear recommendations other than what the science says is like heat is probably a concern for pregnant people, as Dr. Basu just presented. But what your employer says to you is what you probably should follow, because they're your employer. But the employer then is not given any guidance from like their federal or whatever their state policy makers have told them. So we're in this very strange juncture right now where the science is pointing us in one direction, but there hasn't been a policy yet. So as somebody who just, had a baby, I felt like this is kind of cringy. Like, how do you act on this? So that's a fantastic question, and might feel like a subpar answer. Maybe Dr. Basu has more to say about it.
Yeah, I think this is a great question, and thank you for answering that from the occupational viewpoint. That's not my expertise at all. I have heard about pregnant farm workers particularly being affected, but no, it's not just an occupational concern, to answer the question about that, because I didn't mention this, but part of the reason that I started this is because of my own pregnancies, and I realized, wow, talking and reading so much about this thermoregulatory response, and I remember during my pregnancies going, oh, I think this is what I'm feeling now. So I think it's not just occupational. You could just be in a room where everybody else is comfortable, but your thermoregulatory response is compromised. And this happens, whether you're a pregnant person or whether you're just high risk because maybe you have some underlying cardiovascular disease or, for whatever reason. So I think it's really important for public health messaging. I just want to say that even though that, these studies have been out now for 15 years, there's still no policy. And it's just like, there's no guidelines. Pregnant people are still missing. And this is, talk about cringy. Like, this is still like, I see heat alerts and they're talking about high risk populations. I'm like, what about pregnant people? I think that's so important. Probably, arguably one of the highest risk populations you can get, but still being missed. So I feel like we have to keep doing these presentations, keep getting this message out there. While we all know about this, I think it's still not general knowledge.
Thank you both. Yeah, and as a clinician, I would add, I think we need to educate other clinicians as well as medical students and nursing students, so that they can educate pregnant people, about the symptoms of heat exposure, practical things that you can do. I mean, I think most of us know if it's hot, get in the shade, but sort of having people kind of plan ahead about strategies to make sure they stay well hydrated. And none of those are a substitution for a good policy that's going to protect everyone, especially the most vulnerable people, such as the agricultural workers, et cetera. But I think an awareness on the part of clinicians is really helpful. We've got some other great questions in the chat, and actually, I'm just going to mention that Barb Sattler noted in the chat that Climate Resolve is organizing a coalition for the OSHA heat regs and for improved policies in California. So I thank her and her nurse colleagues for the work that they're doing there. The next question is for Dr. Basu. Will you please clarify or repeat the relationship between acute dehydration, oxytocin, and fetal growth / preterm labor?
Sure. I know I went over that really quickly. So dehydration is, as I said, presented in different ways. Body might not just be like, oh, I'm thirsty. And so that's why I think that this is like often missed. I know some people here and are on the call could also probably add to this quite a bit. But from that is what is the trigger to cause this, and this is just one of the mechanisms to decrease oxytocin. And when you increase oxytocin, I said that wrong. When you increase oxytocin, that actually can also increase inflammation, increase like other triggers in your body. And it's not just for pregnant people, it's systemic. So, there could be so many things that are happening in the body. That's why you're getting these cardiovascular as well as these lung diseases. And then after that happens, then it could trigger so many responses, such as premature delivery, growth retardation, and things like that. So it's just like, it's not I really simplified this mechanism, and it's not that simple because there's so many other things that come in between. And that's why it probably is like, hey, how do we get from here to here? But there's a lot of little things that have been discussed in between those. But I just want to just point out how important it is to just think about the big picture, like think about like what this all means, because what's missed is this, again, this connection to heat. So yeah, we have this outcome where you might see, you were talking about clinical in the clinic, like somebody who presents with dehydration, but you just think it's a normal part of the pregnancy. And yes, of course it is, but it's exacerbated by the heat, and that's the connection that's being missed. So all of these parts are just important parts of the mechanism that can occur. I hope that makes sense.
Thank you. Yes, I know, it's not often obstetricians think about heat shock proteins, but some of the basic science research about this, gets that deep. Next question for Dr. Conlon. What are the current knowledge gaps related to heat and reproductive health, and I would add occupational health, that need to be addressed in the near future?
Well, I can talk about the occupational health piece. I think that we've done a lot of work on heat and occupational health. I think that we focus a lot on outdoor workers. There is this very growing space of trying to understand the risk of heat and other indoor air pollutants for indoor workers, right? You can think about when we have really poor air quality specifically during wildfires and really high temperature days, our warehouse workers, people who work for Amazon, they don't stop working. These are non-temperature controlled buildings. They don't have, filters. People are working and they're doing a lot of physical labor. They're lifting very heavy boxes. They're working very long hours. We don't have a very good understanding of how their health is being impacted. So I would say for any graduate student who's really interested in the confluence of heat and air pollution, that population of what would be considered an indoor worker is one that we don't have a lot of understanding on their health impacts. And I think that that is a really interesting area that hasn't been fully explored, but is kind of a population that I think gets overlooked. Not to say that our other outdoor workers don't get a ton of attention either. I think that it's just another population that could get some some attention as well. Dr. Basu, do you have any thoughts on heat and reproductive health outcomes?
Yeah, I think so. When I think about, yeah, I think the main thing missing here is, I was also just looking at a question that was in the chat, is that we talk about studying this a lot, right? And like, I know the indoor piece is really missing. Indoor heat is something that we haven't talked about or studied as much. And that's really important because a lot of our studies rely on ecologic exposures. And that means that it's just like some monitor that we have like in the county, and it could be by the airport, which may not be such a good measure of, you know, individual or personal exposure. And some people have done some personal heat exposure assessment studies, which really shows that, yes, there is a disconnect there. But when you want to study large populations, that's, you know, more challenging. But to just kind of shift, I think the research a little bit, we have identified pregnancy as a high risk group. I feel like now we need to kind of go the opposite direction and go smaller and think about interventions that could work. Because as I said, a lot of this is preventable. So let's not talk about, let's, you know, keep identifying these high risk populations. Yeah, well, we know that there's a lot that we need to address and we need to start there. And as I mentioned earlier, also the public health messaging is like so important because that's also very important for prevention.
Thank you. Yeah, I would agree on the question about interventions. You know, when I've read some of the work about the use of fans in really high heat, you know, at certain wet bulb temperatures, a fan is no longer helpful and may be harmful. And I don't think anyone has looked at that for pregnant people. And so, you know, I don't really know what to tell my patients when we have a high heat event. I mean, I can suggest other things, you know, cold washcloths, cool baths, you know, that kind of thing. But, you know, I don't know the answer about whether a fan is helpful or not. I think we are just about at the hour. So thank you both very much. Ariane?
Yeah. Can you hear me okay? Great. All right. So thanks very much for this wonderful set of insights today, Drs. Lotnick, Conlon, and Basu. And thank you to the audience for your questions and interest in the topic. Our center looks forward to sharing the recording with the registrants and seeing you again on June 12th for our next webinar in the spring series, which is focused on health impacts of climate change across the lifespan. Thank you and have a good day.